Yes, sir.
Please, can you hear me?
Yes, sir.
Yes, please.
Okay.
Yes, sir.
Okay, perfect. Perfect. It's good to know that you can hear me. It's good to know you can hear me. Okay. Let me start by doing what we have to do. Let me share the screen, and then we don't have much time today so that we can continue the lecture. Last week, the network messed us up, but we were able to do something. We started the whole introduction to neoplasia last week. And I remember telling you that there were two tumors that we have to deal with. We had the malignant and then the benign. We looked at the properties that had to do with both the benign and then the malignant. And I remember telling you that one was autonomous, one was not autonomous. I remember clearly telling you that. And then we got to know the effects, right? The effect of, we got to know the effects of these tumors. We said that the benign has its own clinical problems it poses, even though for benign tumors, they have not invaded the basement membrane, neither have they spread to adjacent tumors. But we talked of the malignant, and we said that one key thing about malignant tumors is that they grow rapidly, they spread to other sites of the body, and that is where secondary tumors are formed, and that is where metastasis comes in. We got to know that it causes clinical problems. That is, the malignant tumor causes clinical problems, such as what I have here. The fact that it can grow bigger, and as it grows bigger, it can exert its weight and pressure on the existing tumors, or even on the blood vessels, the arteries, and then the veins. We got to know that there can be ulcerations. People go through pain when it comes to these malignant tumors, and especially when they grow bigger. All these things were gotten, or we understood those things. And I remember a situation we had some time ago where somebody was given 10 pints of blood because the person was at the end stages of cancer, and the person had lost a lot of blood because of the ulceration. Even after the 10 pints of blood, we only could see a very little appreciable increase in the HB. And the reason was simply because whilst you are transfusing, the person, they spread Macintosh on the bed of the person. You turn the person a bit at certain parts of the body, and then you would see clearly blood, some blood oozing from certain parts of the body and all that. So the possibility of blood loss affected the fact that the person has been transfused. And please remember that it can even lead to the production of certain hormones like the human chronic gonadotropin, HCG hormones, right? And then when you have the production of these human chronic gonadotropin as a result of attachment of or growth within the endometrium, the person is not pregnant, but then you do a PT test for the person, and then it will show positive. You do a PT test for the person, it will show positive. The individual will go to take a scan, and then the sonographers will tell the person, well, nothing is in the uterus. Nothing is in the uterus. Nothing is in the uterus, and then clearly it will be not because of any other thing, but simply because the person isn't pregnant, just that there are some growths within the endometrium that has caused the production of these utopic or ectopic hormones. Okay. And all those things were talked about last week with the challenge, even with the challenges we were having when it came to the internet. I saw that somebody wrote that she can't hear me. Please, can you hear me? Am I clear?
Yes.
Yes, doctor.
Yes.
Okay, thank you. Okay. Okay. So proceeding from where I left off yesterday, last week rather, because of the challenges of the internet, I had to run away and leave you guys. Proceeding from there, one key thing we know about whether benign or malignant tumors, or one clear thing we always look out for when it comes to malignant or benign tumors, has always to do with grading or cellular differentiation. Because when you have daughter cells produced from the parent cells, what will make us know that we are dealing with a particular kind of cell from a particular organ is when there is maturation and differentiation. The cell will have to mature and then it will have to differentiate. It's the differentiation that brings the differences in cells of the liver, cells of the spleen, cells of the heart, that's the cardiac cells, cells of the brain, and all that. And so please note that cellular differentiation is very important, and it is based on that we look at grading, because in cellular differentiation and even grading, we are looking at the extent to which these cells resemble the cells or the tissues of origin. We are looking at the extent to which these cells resemble their cells or tissues of origin. What do I mean by that? When you have liver cells, right, and then the cells there go through the cell cycle to produce daughter cells. At the end of the day, when we look at those cells after they've matured and everything, look at those cells and they look exactly like the liver cells because they were from their parent cells, or their original cells were liver cells. Yeah. But one key thing you must note is that when we come to malignant tumors, there are slight changes and differences in terms of their resemblance to the parent cell. When we consider the benign tumors, right, we mostly don't classify them, or we don't grade them. And the reason is simply because they always and almost look like their tissue of origin or their parent cells. And that is why we don't differentiate them. But the differences are seen, right? They are seen in malignant tumors. And so we have 3 grades here. Other books will have extensions of that. We have grade 1, grade 2, grade 3. Or you can look at it in the low-grade tumors, high-grade tumors, and then you have the moderately differentiated tumors. Low-grade, high-grade, moderately differentiated. Or numerically, you can look at it from the grade 1, grade 2, grade 3. When we look at grade 1 tumors, they are well differentiated. What it means is that they almost look like the parent cell, or they look like the parent cell from which they were produced from, or they originated from. The grade 2, in one way, there are some resemblance to the parent cell, but not fully like the well-differentiated ones. The grade 2 is the moderately differentiated. But when we look at the grade 3, they are poorly differentiated. They don't look like the tissue of origin, or the tissue of origin or the organ of origin. I always give this example. The grade 1 tumor is like when a man and the wife give birth, and then the child looks exactly like the father or like the mother. So when the child is just walking about, people look at the child like, are you the son of Professor so and so, or Dr. so and so, or Mr. so and so? And the person might say, oh yeah, I'm the son of this particular person. Oh, that's nice. Good. Or the child will say, he's my father. That is perfect. That one is grade 1, well differentiated. The child looks like either the mother or the father. Okay. In grade 2, maybe the ears of the child, the way the ears are positioned, or the eyes of the child, or the skin color of the child, or something on the child draws the child rather to the family. You look at the child's way of walking, or how bow-legged the child is, or something, and then you are like, is this person, are you related to this person? And they are like, yes, please, I'm related to the person. And you maybe you can say, looking at your eye color, or looking at your ears or your mouth position, your eyes, how they are gorged out and all that. You really look like them. Okay, that is grade 2. But the grade 3, the child looks completely like the landlord. You look at the child's face and everything, and the everything about the child. There's nothing that ties the child to the mother or the father, but then you look at the face of the child, and then the child looks exactly like the landlord. That one is poorly differentiated, because when I relate such a child to the mother or the father, there isn't any form of resemblance, but rather the child looks like the landlord, as I said. Okay, so let's go. Oh, I can see that some people don't like the landlord, so let me rephrase it. Maybe the child looks like a colleague at work, exactly like the colleague at work, the male nurse at the nurses. Okay, so that is it. Anyway, so we move on from there, and then William Nanatando, he said, you have spoiled the matter. I have not spoiled any matter. You and I know that it's true. What I'm saying is true. Sometimes you look at the face of the child, you are whether the child looks like the uncle or any family member, you can't see anything, but rather looks like the male nurse that always sits at the right corner of the nursing station. Anyway, so we have anaplasia, and this is used to describe the situation where a tumor is so poorly differentiated that a cell or tissue of origin cannot be determined even when we use the microscope. That is bad. Although we are saying that we have the poorly differentiated one, but when we say you are looking at anaplastic cells, what it means is that even under the microscope, after you have processed, embedded, microtomed, stained, you view it under the mic, and then clearly it doesn't resemble any cell even within the body. And so you are at a loss as to what you are dealing with. And please note that the prognosis, as in the survival or mortality of an individual, can be tied strongly to the grading of the tumor. The prognosis, as in the survival or the mortality of an individual, can be tied strongly to the prognosis. Yeah, strongly to the prognosis. Now, let me come down to the naming. Let me come down to the naming. Okay, and so please note that for the tumors we deal with, they have names. And all tumors would have OMA as the surface. All tumors, although there are non-tumors or non-neoplastic lesions that have the OMA attached, like the granuloma. And you remember in chronic inflammation, we talked about granuloma. It has nothing to do with tumor. We have hematoma, we have mystoma, aphroma, tuberculoma, and even xanthoma. But in naming or considering the names of the tumors, we will look at the benign, and later we'll look at the malignant. For the benign, we can relate it, benign tumors, we can relate it to either epithelial origin or the mesenchymal origin. When we are talking about the epithelial origin, we know mesenchymal, we are looking at connective tissues here. And please note that for the epithelial, I am here. Epithelial tumors, we can also group them or categorize them into two. We have what we call the non-glandular. It doesn't form a sac. It's not sac-like, right? It is not sac-like, please. It's not sac-like. And so here, for the papilloma, is non-glandular. But we have what we call the adenoma. And in adenoma, we are looking at the glandular epithelium. That one is sac-like, right? And so benign epithelial tumors, we can categorize them into two: glandular, non-glandular, as in papilloma, and then adenoma. And I have examples here for us. Which we will all appreciate. I have examples here for us. We have the squamous cell papilloma. We have the transitional cell papilloma, and then that is for the papilloma, the non-glandular. We come down to the glandular, that is the adenoma, and we have the gastric adenoma, and we have the thyroid adenoma. Gastric adenoma, and then we have the thyroid adenoma. We have gastric adenoma, and we have thyroid adenoma. Let's move on from there. Now we are still on the benign, but then the origin is connective tissue. So we can have benign connective tissue tumors or benign mesenchymal tumors. What I finished right now is the benign epithelial tumors, which we had two categories. The non-glandular, glandular, that's the papilloma, adenoma. We move from there and we are on the benign mesenchymal or the benign connective tissue tumor, where here you look at the origin and you add only the suffix OMA to it. So when we are looking at the fibrous tissue tumors, we call them fibroma. When we look at the smooth muscle tumors, we call them leiomyoma. We look at the striated muscle tumors here, and we call them rhabdomyoma. We look at tumors of the lipocytes of adipose tissue, where we are looking at lipoma here. Then we have chondroma, which is tumor of cartilage. Then we have osteoma, tumor of bone. Tumor of bone. Yeah, so that is it. Please take note of that. Yeah, that is for the mesenchymal. So you have the fibroma, leiomyoma, you have the rhabdomyoma, you have lipoma, chondroma, osteoma, but they are all benign. Please note that they are benign, and then they are of mesenchymal or connective tissue origin. Very good. Now let's come down to malignant tumors here. And interestingly, the malignant tumors, the papilloma tends to become carcinoma. So the non-glandular ones, so we are talking about malignant epithelial tumors, which are non-glandular, they are referred to as carcinoma. So if we are to consider the origin of the epithelium, we will add the carcinoma to it. So we have, instead of the squamous cell papilloma, which was for benign, now when it becomes malignant, we call it squamous cell carcinoma. Here is it. Transitional cell papilloma becomes transitional cell carcinoma. Squamous cell carcinoma, transitional cell carcinoma. These are malignant, but the benign forms were here. Let me show you the benign forms. Here, you have the squamous cell papilloma, but then now it's carcinoma because it's malignant. Transitional cell papilloma, now it is malignant, so it is transitional cell carcinoma. And that is what we have here. When we come down to the glandular, remember this is non-glandular. When we come to the glandular, glandular, we add adeno to the carcinoma. Instead of, previously, if it was sac-like or glandular, it is adenoma. But now we have taken away the oma and we have replaced it with carcinoma. Yeah. So we have what we call gastric adenocarcinoma, or what we know as the adenocarcinoma of the stomach. We have colonic adenocarcinoma or adenocarcinoma of the colon. We have rectal adenocarcinoma or adenocarcinoma of the rectum. We have the pulmonary adenocarcinoma or adenocarcinoma of the lungs. And clearly you can see that all the organs we even made mention of, right? You see they are all sac-like, or they are all sac-like. There is a space in between them. They form a sac or a gland. Okay. But we come down to what we call the carcinoma in situ, which is known as the pre-invasive carcinoma or cancer. And interestingly, for the pre-invasive cancers, right, what you would see or what you would note is that for these pre-invasive, they are malignant tumors. They are of epithelial origin, but because they are far from the route of metastasis and they have not invaded the basement membrane yet, they are not able to spread. And so they are still cancerous, or they are malignant, right? But interestingly, they are at one place. They have not broken the basement membrane, neither have they gotten to the roots of metastasis for spreading. And they are incapable because they are even far from roots of metastasis or roots of spreading to other parts of the body or affecting other organs. Okay. Now we come down to sarcoma. And whenever you hear the word sarcoma, we are talking about malignant mesenchymal tissues or malignant connective tissues, tumors rather. And so instead of the fibroma originally here, look at the mesenchymal, you have the oma, just the origin, and then you add the oma origin. So when we're talking about the smooth muscle, that was the leiomyoma. The striated muscle, you have the rhabdomyoma. We come down here, and then when we are dealing with the sarcoma, which is malignant, right? Here you have the fibrosarcoma. So instead of the fibroma here, now you replace the oma with the sarcoma. So instead of the leiomyoma, you have leiomyosarcoma, you have the rhabdomyosarcoma, you have lipoma. Sorry, instead of lipoma, you have the liposarcoma. Instead of the chondroma, now you have chondrosarcoma. Instead of osteoma, you have the osteosarcoma. That is it. And let me continue by saying that we have teratoma, which has to do with tumors that are related to the testis and that of the germ layers. Yeah, the germ layers. Then we have the blastoma. This one is actually, we are dealing with tumors that are exclusively for children below the years of 5 or below the age of 5. And so we can have a tumor that has to do with the retina. That's the eye. That's where the retinoblastoma. But then we know that it's a tumor of the eye, but then it has affected a child below the age of 5. We have nephroblastoma. We are looking at tumor of the kidneys, but here it has affected a child. Tumor of the liver, but then a child and age below 5 years. So we have the retinoblastoma, nephroblastoma, hepatoblastoma. And we call it blastoma because when you observe such tissue under the microscope, you see that they have resemblance of the embryonic forms of that organ. The embryonic forms of that organ. Now we have carcinosarcoma, where we are looking at a tissue that combines the features of carcinoma and then sarcoma. There are some tumors that combine features here. You have it at one point, or one part of it, or some part of it gives off the appearances of carcinoma, and then another part gives off an appearance of a sarcoma. That is the carcinosarcoma. If you have seen a pathology report before, you would see that the pathology report would give a description, apart from the indication that maybe it's this particular sarcoma or this particular carcinoma. There will always be an architectural description. There will always be a morphological description, some form of description of the growth pattern. And so when you find it forming follicles, right? When you find it forming follicles, then you should note that we are looking at follicular here. So you can see something like follicular sarcoma. You can have cystic carcinoma, right? And here we are talking about, in terms of the cystic, we are talking about forming cystic spaces. We have the papillary ones, which forms this nipple-like projections, especially when you are dealing with some tumors of the rectum. You can have this papillary or nipple-like projections from there. You have villus, where you have this finger-like projections also. And then we have the cribriform, where you have these sieve-like holes or pierced. And so they are small holes there. And so these descriptions, it gives us an idea and even helps us appreciate it, whether it has broken the basement membrane or not, especially when you are dealing with the villus and the papillary forms. Yeah. Okay. So now let's consider how will a person know that some form of malignancy might have developed, or some form of malignancy wants to develop. That's the appropriate word, wants to develop. And this is where we are looking at lesions and some pre-malignant conditions. Some lesions and some pre-malignant conditions. And with the lesions, we are looking at some damages here and there. At that particular point, you can find some damages there. You can find some injuries at the site, a lot, which might warrant some scratches and some sores around that area. It seems to want to heal, and then at a point again resurfaces and all that. And so it refers to identifiable local abnormality with an increased risk of malignant tumor. And you have it even in situations of colonic and rectal polyps. You have dysplasias at that area, especially when you are dealing with cervix. Yeah, when you have these dysplasias, after you have taken some cells from the cervix, clearly it tells you that the person is on the route to malignancy. And it helps when we arrest such lesions earlier. It can actually help us deal with the malignancy. It might prevent the malignancy, or it helps us know how to manage the situation before it gets worse. And in countries where they are serious, and in countries where they are, what do we call it? In countries where the populace or the people are very important to the government, what they do is that when they even find out that you have these pre-malignant conditions or you have these lesions there, they would call you, and then they will always book an appointment for you. And when your due date, when it's closer to your due date, they will give you a call, reminding. They can let an ambulance come around to see if you're out, and if not, they will just keep you in the ambulance and take you there. Yeah. And so we have some pre-malignant conditions here, one which is associated with increased risk of malignant tumors. And you have the chronic ulcerative colitis as one of them. And please, you have to read on it. You have the neurofibromatosis. You have the familial adenomatous polyposis coli. And then we have the undescended testes. Let me mention them again. Chronic ulcerative colitis. We have the neurofibromatosis. You have the familial adenomatous polyposis coli. And then you have the undescended testes. Okay. These are pre-malignant conditions. And even you have cirrhosis of the liver. Cirrhosis of the liver. Cirrhosis of the liver. And so remember what I said. When these conditions are seen and followed up carefully, we are able to help arrest the whole malignancy, especially at the early stages. And you know that one key problem with malignancies or cancers has always been early detection. And so I remember a research work I did, which you can find it on the internet. We were trying to see if there were some proteins which can help us identify breast cancers at early stages. And the particular protein we looked at was the death-associated protein kinase 1. You can look at it, you can look for it on the internet, go to PubMed or Google Scholar, and you'll find it there. It's there. Death-associated protein kinase 1, and it's the first of its kind that was done in Ghana here. You can check it out and read if you are interested. Something of that caliber. Okay, Bruce Lamptey, your hand is up.
Yes, please. So please, I want to ask how an undescended testis is a pre-malignant condition. I'm not
That
getting
is
it
why.
because I know with that, it's just that the babies, especially with the preterm, their testes are not yet descended. So how is it related to pre-malignancy?
The testes are expected to descend after a while, yes or no? After some time.
Yes.
So the problem will be after the stipulated time where it has to descend, and then it is still not descending, then it means that there is a problem. I don't know if you get the point here. It is not at the point. It is not at the point of birth where we know that at that point it has not descended into the scrotal sac yet. That one we all know. But after that, and then it is still not descending, possibly there might be some, it is a caution or an indication of the teratomas we were talking about. You remember teratoma? Rose, are you there, or you asked that you went away?
Sir, I'm here.
Do you remember teratoma? Did you hear me talk about teratoma?
Yes, right now.
So relate that one to the undescended testes. Do you have further questions on that? You can
no,
go
please.
on, but we don't have time.
Okay, thank you.
There are further explanations to that, but that is why I gave it to you as a reading assignment. But the only thing I can add is what I said right now, not to give too much out. What I meant was that simply when the testis has not descended, it's not when you have a baby and then the testis has not gotten into the scrotal sac. But you know that at a point in time, it must drop into the scrotal sac. I hope we agree on that part. Yes or no?
Yes.
When it has not, after the stipulated time, if it has not dropped into the scrotal sac, what could possibly be the reason? Rose, I'm asking.
Then that one, I can't really tell.
So I'm giving you some indications that you can relate that one to the teratoma, and there is a fine link between that one, and even further complications with other organs, even within the body. Yes. Okay, I think I saw another hand up there.
It was my hand, but it was the same question that I was going to ask. I'm not getting the link. The link there.
You said you are not getting the link there.
Yes, please, sir.
I can't hear the voice.
Sir, I'm not still getting it. Like why the undescended testes would be precancerous.
Why would the cirrhosis of the liver be precancerous? I'm asking.
The cirrhosis of the liver, I think that one is a disease. It's a disease aspect of the liver.
And
you
said it's a disease aspect of the liver.
Of the liver, and per the previous knowledge that we had on the I think that there are some, like you said earlier, on the teratogenic agents that might be found in the body that may cause it to be cancerous.
I don't get what you are trying to say. You said the teratogenic what I explained earlier is what you are trying to relate here.
No, you asked of the liver.
Obviously, for even the liver, I hope you know that cirrhosis doesn't mean that it is malignant yet, right? I hope you know that. And even doesn't suggest, it doesn't even suggest a tumor.
Yes, sir.
So if it doesn't suggest, so I think I have to take you through this mechanism first. What happens is that, you know, when we talk of cell cycle, right? All the cells to produce daughter cells, the cells will go through the cell cycle to produce daughter cells. And you know that with the cell cycle, there are gatekeepers. We call them gatekeepers. And so if a parent cell is going through the cell cycle, it gets to the G naught, and then there is an inspection. And when we do the inspection and they find out that there is a problem with the DNA, there are damage, there are mutations, what happens is that it will push it to the senescence or the G0 point for them to, that is at the S phase, for them to have what we call a checkup on it. When there is a checkup and then repair is issued and repair is done, then it can get back into the cell cycle and go through the cell cycle to produce daughter cells. I hope we are on the same page on that.
Yes, sir.
But when there is a damage and then it's irreparable, that is when you have the what we call the apoptosis to occur. But when there is a refusal of apoptosis, because there can be a refusal of the apoptosis, and there can be a challenge with the gatekeeper genes and the caretaker genes. These gatekeeper and caretaker genes, when they fail, they are like the checkpoints. When they fail, even though there are mutations in the DNA, it will still produce mutated daughter cells. And these mutated daughter cells will further produce daughter cells at a shorter span. And that is where the tumor comes in here. And that is where the malignant comes in here. Because under the whole scheme of carcinogenesis, we have a complete change from the normal to the abnormal. And for some of them, when there is that change, it doesn't develop straight away into a tumor. And that is where the carcinoma in situ comes in here. Even though the cells there are malignant cells, because of the damage with the DNA and then the mutations that have gone on in there, it can still not produce a lot of them, even though it's malignant. I don't know if we are on the same page in terms of even the cirrhosis.
Yes, please. We are on the same page.
Very good. So now let's come down to the undescended testes thing and the whole teratoma thing I was talking to you about. So we expect that it must descend. Why? The question here will be, why is it not descending and what has caused it not to descend? And that is what actually gives us the information of a possibility of malignancy of the testes. I hope we are on the same page. Are we on the same page or not? And the heavens were quiet.
Yes, sir.
Yes, yes, we're on the same page. Yes.
No. He still doesn't understand. The gentleman, are we on the same page?
I'm not actually getting it.
Then what I will do to you is to let you go. What I will do to you is to let you go and read.
Sir, what I was thinking is that what I was thinking is that if the testes are not descended, I think something is blocking it. Maybe there has been like early closure of the foramen over there, where the testes will pass to descend into the scrotum. Maybe it has been closed.
And that is why it's not descending. And so you think that based on that, it is not a pre-malignant condition. Is that what you are trying to say? Is that what you are trying to say?
That's what I was thinking, sir.
You see, the problem is that you are using the old knowledge you have to answer a new question. And I'm teaching you something new, and you seem not to want to open your brain to the new thing I'm saying. You are still thinking of the fact that something might have blocked it. If something might have blocked it, are you trying to say that it's because maybe an organ has now increased in size so much that it has actually blocked the descending of the testes?
No, please, sir.
Is that what you are trying to say?
No, please, sir.
So I'm just trying to explain to you that there is the possibility here.
Okay.
Hey, hello. Why? Are they listening to me, please?
Yes, we are.
So I'm simply trying to give you a different scope in terms of pathology here, and the possibility of a tumor here. And you are always going back to the fact that something might have blocked it. That one can be an issue, yes, but that is not the reason why it is a pre-malignant condition.
Okay.
The blockade might have prevented maybe a flow of blood or whatever it is to the site, but that is not the reason.
Okay. Okay.
So we have Hamdia here. Please let me advise on this. It is good that you have some knowledge about something and the reason why it happens that way. But when it comes to pathology and we are explaining how it is, please take it from what we are telling you. You can do a further, that's why I've given you the opportunity. You can go on the internet and then check from PubMed or even from Google Scholar, there are published works on what I'm talking about in terms of undescended testes and the malignancies. Check that one out. You can look at that.
Thank you.
I've given you a source. I'll be happy you go and read, and then next meeting or anytime, you just contact me and then we can talk about it, even as lectures are like this. So next week, based on that, I'll allow you go and read, and then you come back. Okay. Okay. So any other? I think I saw a hand. Was it Hamdia's hand or something like that? Someone like that.
Hello. Yeah. Yes. Hello, sir. Please.
Yeah, Hamdia.
Yeah, I was trying to also clarify from the initial knowledge that we have is that usually when we have undescended testes, it's usually the inguinal canal that is not opening. And mostly how it is resolved, when the child is like 2 years, the doctors will just do surgery and open up the canal for the testes to descend. But this is like a new knowledge or information that it might be. It's not always the case. It might also be like a pre-malignancy, as you were saying. So it's just a clarification.
When you read, you even go back on this word, the chronic ulcerative colitis, look at the neurofibromatosis I have here, and even the familial adenomatous polyposis coli. Just take your time and read on it, and then try to look at, don't just Google chronic ulcerative colitis or whatever. No. Just type chronic ulcerative colitis in relation to malignant tumors, or you just write the chronic ulcerative colitis and you write increased risk of malignant tumors, and then you see it draw the fine lines between that one for you.
Okay, sir. Thank you very much.
Well, come on. So let's go on to the spread of the tumors. Let's go on to the spread of the tumors, where here we are looking at the what do we call it? Metastasis. And when we are to differentiate between benign and malignant tumors, one single most important mark or criterion or standard or whatever it is you call it that differentiates them is actually invasion. An invasion here means that the tumor has broken the basement membrane. The cells there have been able to breach the basement membrane. And whenever they breach or they break the basement membrane, then it means that possibly it is getting to what we call channels of spread or routes of metastasis. Channels of spread or routes of metastasis. And possibly the invasion or the invasiveness is as a result of its ability to be motile. Because please note that normal cells are not motile. Normal cells are not mobile. They don't move about. Because of the cell adhesive junctions, they are attached to each other in that order. But you find out that malignant cells or malignant tumors, the cells are motile. And that is the only way it can spread. From where you are sitting, the only way you can get to the next room or the next place you are thinking of will be by you walking or finding your way there. But if you are stuck to your seat, you cannot go through that. And so we have the increased cellular motility. We have the secretion of proteolytic enzymes like the metalloproteinases. The release of proteolytic enzymes like the metalloproteinases. And then we have the decreased cellular adhesion. Because unless the adhesive junctions are loosened, there is no way it's going to be able to find the motility, not to talk of even the increased motility. And so note that it is abnormal for cells to be able to move about like that. It's abnormal. It's abnormal for them to be able to move about like that. And so the whole idea sometimes is to arrest the migration or the motility thing. Let me quickly add that the body also releases what we call the tissue inhibitors of metalloproteinase. That is the TIMPs, tissue inhibitors of metalloproteinase. And this is a counteract to the metalloproteinase, which is released as enzymes to ensure that the cell is able to move about. Yeah. Tissue inhibitors of metalloproteinase. That means that for the cells to be able, malignant cells to be able to move about, it has to what we call down-regulate. That means that the effectiveness, the potency, and then the level of the inhibitors of metalloproteinases must be down, or must be less, or must not be there at all, so that the metalloproteinase can now allow the movement of the malignant cells. Yeah, it can allow the movement of malignant cells. Yeah. Okay. So now let's look at the steps in metastasis. Let's look at the series of steps involved in metastasis, and we call it metastatic cascade. Metastatic cascade. Metastatic cascade. That's what we call it. The first one is detachment. 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 And in detachment, you know very well that because of the surface adhesive molecules like the cadherins and the others, the cells must find a way of ensuring that it loses its effectiveness and its adhesion so that it can move from there. So it must be able to detach itself from the other cells that are available. It must be able to detach itself from the other cells that are available. Yeah. Yes. And so going on from the detachment, we have the was it the extravasation? Let me look at it. We have the invasion, rather. Yeah. We have the invasion here. That is, we have the invasion, which is the next one. And for the invasion, this is where it is able to down-regulate the tissue inhibitors of metalloproteinase using the metalloproteinases. Now it will begin to break the basement membrane after it has gotten the opportunity to detach, to begin to move from there to other parts. And by the intravasation, now it finds itself, because it has now broken the basement membrane, it now finds the channel of spread, which is the intravasation, the lumen, the blood vessel. That means that if it's using the blood vessel, somebody has the audio on. Somebody has the audio on. Bernard Dakura. Bernard. You see, Bernard Dakura is just on, but, and then Winifred, please mute. Okay. So let's go on. So we have the intravasation, and I was talking about the fact that you will have it moving from the basement membrane. Now you would have gotten into the blood vessel, that is the lumen. And that one, it would have spread by the Rose Lamte. Rose, your hand is up.
Yes, please.
Yes.
So please, can you explain the metalloproteinase to me, and then the tissue invaded metalloproteinase? It's like, are there the enzymes responsible for the carcinoma being able to invade or to move?
Yes, the metalloproteinase is for the movement, for the detachment, and allowing it to also invade as well.
Okay.
But then the tissue inhibitors of metalloproteinase, they are actually the ones that prevented the movement initially. So if now it wants to move, if the metalloproteinase wants to have a free flow and free activity, then there must be what we call a down regulation of the inhibitors of the metalloproteinase. Okay,
so there will be reduced tissue invaded metalloproteinase, so that's the metalloproteinase to be able.
No. I'm still not getting it. There will be a reduction in the inhibitors of the metalloproteinase. Metalloproteinase are there. They are there to ensure that they are able to spread or be motile and then be invasive. But then, because originally we don't want it to be motile, because if it is not malignant, the benign forms, there are what we call the inhibitors of the metalloproteinase. Because the moment the metalloproteinase are released, they are to ensure detachment and ensure invasion. And so when you have the inhibitors of metalloproteinase, its duty is to prevent that. But immediately now it becomes malignant. It tries to downregulate it. It tries to limit the effectiveness of the inhibitors of metalloproteinase. So that now you have more like an increased metalloproteinase, but a drastically reduced or a non-functional inhibitors of metalloproteinase, so that it can now invade or spread. Are we on the same page?
Yes, please. Thank you.
The way you are responding, I think you are not.
Oh, sir, I understand it.
What did I say? Okay, summarize what I said. I want to know if you understand.
So what I understand now is for metastasis to take place, there should be an increased number of metalloproteinases. So whenever there is increased number of metalloproteinases. I
didn't use the word number. I said increased level.
Okay, increased level of metalloproteinases. Then there is down regulation of inhibitors of metalloproteinases. In order for the metalloproteinases itself to move.
No. Okay, I say one thing. No. In order for the malignant cells to have the free course to be motile or mobile, for them to be able to detach and then be able to break or invade the basement membrane. Do you get the point?
Yes.
Okay, so let's go on. So by this time, we know that it has gotten through to the blood vessel, as in the lumen. It can be the lymphatic vessels, it can be the blood vessels, like I said earlier on. And it has a challenge here, because remember that within the lumen, especially if it's the blood vessel, you know that you have your neutrophils in there, your lymphocytes are there, your eosinophils are there, and they are responsible for their phagocytic cells. So if they find any foreign thing in the blood, they have the opportunity immediately to phagocytose it and clear it from there. But you find these malignant cells still escaping whilst it is in the blood vessel with the neutrophils, the eosinophils, and all the cells that are responsible for phagocytosis in the blood vessel. And the reason is because it is able to reduce the expression that makes it an antigen. It is able to reduce the expression that makes it an antigen. So let me go deeper. Since today, I think I have to go deeper for you to understand certain things from the pathological perspective. What happens is that for cells to be able to identify foreign cells, as in for the phagocytic cells to be able to identify, there must be expression of certain receptors on their surfaces. And that is how they are able to know that now this particular cell or this particular thing is not part of us. It's foreign, so we must clear it from there. Yeah. And immediately it's able to do that, then it solves the situation. But when we are talking about these malignant cells, they are able to ensure that such expressions on their surfaces are reduced, so that at the end of the day, when it comes in contact with neutrophils and all the other cells that have the propensity and the capability of phagocytosing it, it sees it as part of them. So it's like somebody not being part of the military people, and then he goes to wear a military attire and then joins them in their jogging. So even though you have these cells being malignant, which needs to be cleared of phagocytosis, but because of the down-regulated expressions or the reduced expressions of such receptors, which is responsible for their identification, it is able to escape. Okay. I hope we are on the same page. Let's go on to the next one, which is adherence. So in the same vein, just like I told you about the pavementing and then the my imagination, pavementing, transmigrations, or the appendices, you remember those ones? That is employed here in adherence. And so just like you have the normal expressions of integrins and then the glycoproteins on the surface of the neutrophils. You will have expressions of the integrins and glycoproteins on the surface of these malignant cells. And it will release enzymes and then force the endothelial cells to also express the P-selectins and all the complementary ligands or complementary receptors so that it binds to it. And when it binds to it, what happens then is that it moves through, just like the neutrophils would have done, into the tissue space. And when it moves through into the tissue space, this is where now it forms what we call a secondary tumor. So note, it might start from the liver, right? But the secondary tumor might be formed in the bladder. And this happens especially to areas where you have a low flow of blood. The flow of blood is not fast at those areas. Irene, your hand is up.
Please, can you go over the adherence again? Please.
Okay. So the adherence is simply this way. You have, just like, what's her name? The lady that spoke right now.
Irene.
Irene, do you remember your inflammation properly?
Yes, please.
Do you remember the steps in inflammation in terms of the cellular event?
Yes, please.
What were they? Make mention of them.
So in the cellular event.
You are now opening books, eh?
Oh no, sir.
I can hear chiri. I say no, sir.
So I'm not even at where the books are.
Let's talk. Give me info.
So the proliferation phase. So I can mention them, but not in order.
Okay. So you remember that we had the margination pigmenting. We had the transmigration, also known as the diapedesis as well, right?
Yes,
please. Do you remember that? And then we had the chemotaxis.
Yes,
and all
please.
that. It employs the same thing here, especially with the adherence. There will be the release of the integrins and even the glycoproteins, specifically the integrins, and then the complementary receptors on the endothelial cells, so that it can be able to bind or hook onto it. And then it will find its way between the endothelium and then get to the basement membrane and then release the enzyme. And when the enzyme is released, it breaks and then gets into the connective tissue space. And interestingly, when it breaks and gets into the connective tissue space, then it will begin to form a secondary tumor there. And I said earlier on that it can start from the liver, but the secondary tumor will be found within the bladder.
Okay.
It finds a part of the body where the flow of blood is slow. The flow of blood is slow. That is where, because when it's very fast, it wouldn't have the opportunity of adhering.
Okay.
And the interesting thing is that when it adheres, rather when it gets through, and then it begins to form the secondary tumor, it will release what we have here, what we call the vascular endothelial growth factors. So that now angiogenesis and neovascularization can start.
Okay.
And the sad thing is that when it forms these canals, if you remember angiogenesis, I told you that you have the budding of endothelial cells from existing capillaries to the site where the malignant tumor is now. That is where the secondary tumor is. And the reason is to supply it with rich oxygenated blood.
Yes.
And then blood that has nutrients so that it can feed the cells there, that is the malignant cells in there, so that they can rapidly grow and become bigger to form another tumor.
Okay, sir.
Okay.
Thank you.
Always welcome. So now let's look at the roots of metastasis here. The roots of metastasis here. The roots of metastasis here. Let's look at that one. And then we have them as in 4. We have the hematogenous spread or hematogenous. We have the lymphatic and we have the transculiomic. Then we have the implantation, seeding, or transplantation. We have the implantation, seeding, or transplantation. So for the hematogenous, the lymphatics, transculiomic, and even implantation, what happens is, let me pick the first one, hematogenous. So the blood vessels. The blood vessels are used here, bloodstream here, and then it forms a secondary tumor at a distant organ. Then we can also look at the lymphatic vessels, where we are looking at the formation of a secondary tumor in regional lymph nodes. Then we have the transculiomic, where here we are looking at the pleural pericardial cavities. Spread through the cavities of the lungs, cavities of the heart. Yeah. And the other one will be the implantation, seeding, and transplantation. And amongst all of them, this is the saddest part. Because you see, there can be some tumors that are pre-invasive, as in carcinoma in situ, right? They are pre-invasive. If they are pre-invasive, what it means is that it has not gotten to the roots of metastasis, or it is very far from the roots of metastasis. But the challenge we might have is that when there is a surgery on the individual, and then the surgeon opens that part, and there is spillage, accidental spillage, or the surgeon opens that part, and then it flows and gets in contact with blood easily. The cells that are waiting for an opportunity to spread can have an opportunity to now spread to distant organs and begin to cause a problem or a challenge. Are we on the same page, please? Okay, so Stephen, you can talk, please.
Hello, sir. I'm confused here.
Okay.
Let's take it that someone who has the cancer cells, the tumor cells in the blood. And
that's leukemia.
Unfortunately, there is exchange of blood with someone who also don't have. Is it possible the person who don't have can also develop the cancer cells?
Come again. I didn't get the latter part. You are talking about leukemia.
Yeah. In case someone is having a cancer cells in the blood.
But I hope you know that in terms of leukemia, the leukemia, we are dealing with the white blood cells here, not the red blood cells.
Yes, sir.
Yeah,
so I was confused that yes, sir.
So let's go on. Or by that, when your question has been answered, can he hear me?
Sir. Yes, sir.
The question has been answered.
Yes, sir.
Okay. Then I'm sure that you were thinking that the leukemia has to do with the red blood cells. Okay.
Yes, sir. Yes, sir.
Okay, let's go. So we move on from there, and I have some information here. The fact that carcinomas tend to spread by lymphatics, while sarcomas prefer hematogenous spread. Remember that, because it will come in the exams. Carcinoma tends to spread by lymphatics, while sarcomas prefer hematogenous spread. And the organs commonly involved by hematogenous metastasis are the lungs, the liver, and even the bone. The lungs, the liver, and then the bone. So look at, let me give a disclaimer. I'm coming to show you some images which might not be very nice to the eye. And so please be cautioned on that. So this is liver metastasis. So when it's spread, you can see that it's trying to form some tumors in there. If you look deep within, this liver metastasis. Look at this one, splenic metastasis. Here, if you look closely to it or at it, you see them beneath. I hope we can see. Can we see those tumors beneath it? Can we see?
Yes,
Yes,
sir.
sir.
Yes, please.
So you
Yes,
can
sir.
see,
So
yeah.
we can
So that's how it is. Now let's look at the clinical problems here, and then its effects and all that. So clinical effects of tumors attributable to their location, the cell type, or the tissue of origin, and then we also can look at the behavior. So the effects can be local or systemic, and in terms of the local, we have the compression and displacement of adjacent tissue because of the increase in size and all that. You have the invasion and destruction of malignant tumors, which I told you can even lead to loss of blood here and even causes some pain. Very important to note that it can lead to compressions of even the spinal cord and all that. Yeah. But when you move from the local and then you look at the systemic, you have the nausea, vomiting, retching, anorexia, cancer, cachexia in the wasting of the muscles, and then you have the weight lost. And let me say that these are even the more reasons why early diagnosis of malignancies or cancers have become a challenge. Because please remember that the normal or the diseases we troop to the hospital every now and then with would present itself with these symptoms. Please, whoever it is, mute your thing. Tete Ebenezer, mute. Yeah, and so we might be thinking that, well, maybe it's malaria, it might be another thing, that kind of thing. We'll be suspecting other, and we'll be treating typhoid, malaria, and all that. So you go to the person's house, and it's like the person has a mini drugstore or something there, where all sort of drugs are there. And all because we have not been able to, and interestingly, we don't have oncologists within even our district hospitals. We don't have oncologists to help with these early diagnosis. You only have them within the regional and within the teaching hospitals. Even the regionals don't have them. And so, or maybe few of them, because they are very few in the system. And so you have our MOs trying to do very less in terms of that by just giving them the artesunate amodiaquine and all the things you can think about and all the other drugs you know of, thinking that we are dealing with malaria. And so you can see the same fever, you have cancer, cachexia. Yeah, Rose, I can see your hand again.
Sir, please, so in case we have the oncologist, is there any means by which such labs can be included? I don't know whether you understand my question, but in case I have fever, vomiting or nausea or something like that, you see, they will do RDT for me or BF for me, and then do maybe probably the, how do you call it? Typhoid test for me. So with the cancer test, is it that they will take the blood sample and then study it for cancer cells, or they will just cut any part of it?
The reason why the oncologist will have a problem at the district hospital is because the oncologist would have to work hand in hand with the pathologist, where we have a pathology unit, right? Because what happens is that, I hope you know, Rose, that we can have slaughtering of cells into even the urine of an individual. And if a person is trained to know the differences in terms of these cells, in terms of the maturation and differentiation, they can tell whether a malignancy has started, and even when a person is responding to a drug or not, in terms of malignancies. Rose, I hope you know that.
Okay.
But what's the scope of training of our med-lab scientists in the district hospitals and all those ones does not capture those things. So even when they look under the mic and you presented them with, let's say, blood, and they even did a thin film, there will be certain changes within the cells there which they cannot identify because their training doesn't expose them to those things. But the pathologist and the oncologist, when the person sits before them and then they start having conversations, because their training gives them a wide insight as to what to suspect and what to request for. They are able to easily arrest such situations than the normal MO, whose scope of training is limited in terms of these things. I hope you know that the symptoms that we present and even the signs that we present with to the hospital, right, and to the clinician, we have a million and even more explanations to it. The only thing is that our trainings are limited to a certain extent. And so when you have a specialist or a consultant, his knowledge and vast array of insight in that same area, when those symptoms and signs are presented, his explanation and interpretation will be different from the MO. Rose, do you get the point?
Yes, sir.
I hope I helped.
You help, but I want to know if the explanation you are giving, it applies to all malignancies or cancer, because maybe if somebody is having the cancer of the bladder or something like that, the cells might be found in the urine to differentiate it from the, but maybe somebody having cancer of the lung or the breast, is it possible that one to be seen in the urine or the normal blood?
Obviously, we are looking at where the organ is and then the fluids that are found at that area. And so if you are looking at leukemia like this, somebody can decide to do a thin film because the fluid that is there will be the blood. Is that not the case?
Yes.
If you are dealing with bladder cancer, it's because you have urine there that can easily have them pushed out with the slaughtering or some of these cells of the bladder in the urine. That's why when you spin, you are able to see the cells. You have the deposit, you look at the cells, and then you can report on them. But one thing is sure, that it will present with these systemic factors. I don't know if you get it. If somebody comes to the hospital, let me give you a typical example, and then the person says that, look, I'm not feeling okay. I all the time I have a rise in temperature. I feel very feverish and I'm not okay and all that. I hope you know that the first thing we'll do is to ask the person to go and do BF for MPs. Yes or no?
Yes.
Yes. Yes.
The parameters, have you ever viewed a slide, a thin film under the microscope before?
No.
Rose, to ask a question now, when I even explain to the barest minimum, you can't even understand. The simplest thing is that, yeah, that is why I shouldn't worry my head. Because what I said is, if you had an knowledge about what I'm saying, so simply put, what I'm saying is that these symptoms and all these systemic effects I'm talking about, including even the physical effects, they give pointers to malignancies, regardless of where they are found. That is all. Hamdia, your hand is up.
Yes, sir.
Yes, please.
I'm going to talk about, depending on what Rose was saying. You know, some of these health facilities, when you take complaints such as these symptoms that you just gave us, the fever, the loss of weight loss, and sometimes, you know, some of our facilities, when the PAs or sometimes we consult, and you could see that clearly you've done all the basic labs that are available, the typhoid, the MPs, the age, everything is okay. And you don't know how to go about further investigation. And this malignancy that you are talking about, early detection is very paramount. So at the end of the day, it seems like the mass public is suffering and we don't have a way to help them for early detection. The only cancers that we are able to do early detections are the cervical and the breast, the common ones. But
even with that, Hamdia, even with the cervical ones, I hope you know that we don't even have cytology labs. Yes. A lot in Ghana.
Yes.
Unless people come around to do screening and then they take the samples away because of research and then they will bring back the report. And then the physician or the PA would call the person and then tell the person that, well, you need to go to the regional hospital or somewhere because your report is saying that you need to be attended to immediately.
Yes, and even sometimes when we do try to refer, You don't know how to put it to maybe the prescriber, or that you want the person to do analysis for maybe cancers or something, because somebody will tell you clearly that he's losing weight and you've done all the minor labs that you are supposed to do at your level and you are not finding anything. So now if you refer the person to the next facility,
you get what I'm trying to say. And so this is where the limited knowledge comes in here. Because no matter what, just like you said, you would have done the basic labs, everything is fine. And sometimes if you have not gotten certain understandings, you go to the lab and even fight with them, thinking that they didn't do the lab. And you think that this person is feverish, and you are saying that nothing is wrong with him. Look at the temperature, look at this and that. But simply because it might be something either than the malaria parasites you were expecting to find in there. And that is it. And that is a big challenge, Hamdia, because you see, I have a problem with that. In the whole of Ghana, do you know that we don't have even pathology labs? Pathology labs, we don't have up to 20 of them in the whole of Ghana.
Yes, it's true. I think even in Kumasi,
in Kumasi, it's only Konfanoche and Hope Exchange, and then some few private, about 2 private labs.
Only part that we have is like that.
So apart from that, it's quite a challenge, and that is the whole issue. And that's why before we would know it, and before the person comes to maybe cut for them to know, the oncologist and the other people there to really know what is wrong, it will be at the late stages where now it has metastasized to not just a single organ, to about maybe 2-3 organs in the body. And it's unfortunate that in Ghana here, we are not the government, not any particular government, but I'm talking about successive governments have come, and we are not interested in trying to build our various district and the regional hospitals to a certain class or standard. You travel outside Ghana, and then a university hospital is even far equipped than our teaching hospitals here. Far equipped than our teaching hospitals in Ghana here. Okay, so now let's quickly round up looking at the carcinogenesis. And in terms of carcinogenesis, we are looking at a process which results in the transformation of normal cells to neoplastic cells by causing permanent genetic changes. By causing permanent genetic changes. The word is permanent genetic changes. They are not reversible. And please note that tumors arise from a single cell that becomes transformed by cumulative mutational events. And you have spontaneous mutation during normal DNA replication. And when that happens, there can be repair or rectification, like I told you. But if it resists the repair by ensuring that the checkpoints, the caretaker genes, and then the regulatory genes are damaged, then what it means is that even though there were damages that could be rectified, it will not be rectified. The daughter cell will be produced still with the damages. And let's get to know this, that we have carcinogenesis there, which specifically means malignancy. But we have oncogenesis, which refers to the causation of all tumors. So oncogenesis encapsulates or captures both benign and malignant. It captures both benign and malignant, but the carcinogenesis is only for malignant. Okay, so this is where we have the carcinogens. This is where we have the carcinogens. This is where we have the carcinogens. The carcinogens here, we are talking about the cancer-causing agents. We are cancer-causing agents. And then the agent is said to be carcinogenic and is called a carcinogen. And in terms of oncogen, we are looking at a tumor-causing agent, but note that a carcinogen can be a subset of oncogen, because we said that oncogenesis is tumor formation, both malignant and benign. Both malignant and benign. Please, let's take note of that. Both malignant and benign. Okay, so that is it. And then we can have mutagenesis or mutagens. So the carcinogens or the oncogenes act by causing DNA alteration, and that is mutation. And it is from that that we have the mutagens. The mutagens causes, the mutagen cause mutations, right, to the DNA cells, the DNA rather. And then we have the main classes of carcinogenic agents. We have chemicals, we have viruses, we have radiations, where for the radiations we have the ionic, and then we have the non-ionic. We have the ionic, we have the non-ionic as well. And let me well, not only hormones, but we also have bacteria, fungi, parasites, and then you have miscellaneous. For the chemical carcinogens, please let's note that from the various pomades to the drugs we take to the various chemicals we apply on our head and our body and whatever you can think about. Please note that some of the chemicals in there are cancer-causing agents. And some of them are indirect acting. For the indirect acting, what it means is that it must accumulate to a certain threshold before it can cause mutagenesis or it can cause damage to the DNA. But the direct acting ones, few just coming in contact with a little of that can cause damages that can be very deleterious or very dangerous to an individual. Now we come to the radiations here. We have the ionizing, which we have the ultraviolet light here, and this is derived mainly from the sunlight. And the low penetrating power so causes cancer on skin exposed to, they even go to the beach, they have the sun tanning cream, ultraviolet rays, and can lead to skin cancer. Protected radiation, putably. So there are some radiation. Hello.
Hi.
Hi.
Did
Sir. Your line is breaking.
Yes.
let me share again and then we continue.
Okay, sir.
Okay. Can you see my screen?
Yes.
Sir.
Sir.
Yes, I can see your screen.
Okay. So just like I was talking about the ionizing radiations, and we said that for that one, it causes it becomes dangerous and it's carcinogenic only after a long-term effect or in contact with it. Please remember that these X-rays and all those ones, that is why we advise that they take or they put on protective clothing to prevent the effect on them, because when they are accumulated for a while, it can actually cause problems of the thyroid, the breast, and even hematopoietic challenges. Okay. We also have hormones. Where we are looking at, okay. We also have hormones where we are interested in some hormones like the estrogens. We know that the promotion of estrogen leads to the development and then the growth of the endometrium and the breast as well, especially when ladies are in their puberty or when they are pregnant. The enlargement of the breast is as a result of the estrogen, the hormones that are produced in certain quantities, which I've talked about before. And please remember that when these hormones are no more needed, but they continue to be produced. What it means is that it will continue to cause hyperplasia. And when it causes hyperplasia to a certain extent, then tumor formation is inevitable. That's why you can have this endometrial hyperplasia, endometrial carcinomas. Yeah. Okay. Then we have the androgenic and anabolic steroids, which induce hepatocellular tumors in humans. Sorry. Then we have bacteria. We have bacteria were implicated in the development of gastric lymphoma. The Helicobacter pylori has been implicated in gastric lymphoma, even though it is known to cause peptic ulcer. Are they there?
Yes, please.
Yes, sir.
Is Rose Lamke there?
Yes,
Rose
sir.
I'm
Lamke.
here.
You are quiet too much. Rose, I hope you know that whenever we made mention of Helicobacter pylori, we know that it is related to either gastritis or peptic ulcer. I hope you know that, right?
Yes, sir.
But I'm also telling you today that Helicobacter pylori can cause gastric lymphoma.
Okay, sir.
Then we have fungi. Then we have fungi, where you have aflatoxins, specifically the Aspergillus flavus. It is implicated, and there are researches, publications that have indicated that they are responsible, or they can actually cause liver cancers, hepatocellular carcinoma. We have parasites such as the schistosoma hematobium, which is known to cause bladder cancer. Even though we know that when we are talking about schistosoma hematobium, then when the person brings urine, it has to be bloody urine and all that. Research has shown that it has been implicated in several bladder cancers as well. Then we have the Chilenosis sinensis, which is a liver fluke, which has also been implicated in bile duct cancers. That is the cholangiocarcinoma. Then we have the miscellaneous, like the asbestos. By inhalation, we know that it also causes mesothelioma as well as the lung cancers, or carcinoma of the lungs. Then we have metals, people that work with metals, those that work with making gates and iron rods and all those ones. Exposure to compounds containing even nickel led to a risk of carcinoma of the nasal cavities. That is not all. We have other metals which we can't even talk about. And all of them are known to be implicated in these nasal cavity issues and then lung carcinomas. We have wood, those that are in the sawmills. Yeah, the sawmills. That is why we advise that they have this face shield rather, and then the nose mask, because inhalation would lead to, before you know it, you have developed some cancer of the nasal cavities. That is not all. There are stone quarries where they blast these stones, and then we have the gravels for building our houses and all that. Those that work there are at serious risk, and they can easily develop lung cancers also. But we have what we call the host factor in carcinogenesis, where under the host factor we have race and we have diet. We have race and we have diet. And for the race, I hope we all know that there are certain cancers based on the geographical location, the diet, and the habit of the people there. It looks like it is for some particular people. As I said, in Africa, hardly do you find skin cancers because of the melanin, by God's grace, we have. Yeah. There are certain cancers, if you look at cancer statistics, when you Google and then you go to Google Scholar, PubMed, or any of the good search engines, and then you decide to look at cancer statistics in terms of race, you will see that there are certain cancers that are for the whites because of their location, because of their diet, because of their habits. And there are certain cancers that are kind of for the black man. You remember that even not cancers, I'm deviating a bit from here. You remember when we were talking about keloids, we talked about the fact that in terms of, because of the race effect, it only affects the blacks. Hey. Okay. So we have the next one, which is diet. And we know very well that high fat or high dietary fats puts a person at risk of breast and colorectal cancer. Please note that alcohol is suspected to increase the risk of breast cancer and esophageal cancers as well, and even that of liver cancers. Please take note of that.
Alcohol.
Yes, so Bema, alcohol. And that one you should know. It's not only the liver cancer, but I've told you, even breast cancer. Even breast cancer. And even esophageal cancers as well. Yeah. Let's come straight away to the fact that the diet may lack protective factors, and that is how come it will lead to that. And then you have what we call intestinal transit time may alter exposure of gut mucosa to carcinogens in diet. When we move from the race, the diet, we come to what we call the constitutional factors. And research has shown, I repeat, research has shown that if you are from a family where breast cancer affected your grandmother, maybe an auntie, and some close relative, the possibility or the probability of having or developing breast cancer is 50%. If your father, your grandfather, an uncle of yours suffered some prostate cancer and all that, research has shown that there is the possibility of or the probability of 50%. Yeah, 50% of developing. And that is why if in your family, you know that there is the constitutional factor, that is the inherited predisposition, you check your diet. It's important to look at this thing here. So you check your diet. That's why this is here. You check your diet and your alcohol intake and all those ones. Okay, and it's also better to even exercise. And the next one will be age. Please take note of that, age. I remember somebody asked this question some time ago about age. Yeah, Daniel. Hey, Daniel.
Hey, yeah, you guys can have it. Another who's going to be a vaca.
Sir.
Osei, are you there? Osei, please come online and speak. Osei, please inform Osei that I need him to come online right now. I want to speak to him. Before I end the lecture, I expect that he comes online.
Hello, sir.
Is everything okay?
Yes, please. I was taking money from someone.
Hey, Chairman.
Sorry,
Pathology
sir.
Yourself. If you don't want to be part of the lecture, you just mute it, or you can even decide to leave. Why? Okay. And let Nanado have his peace. Daniel, let's talk, please.
Sir, please, on the side of the diet, that I want to clarify something. Whether the packaging of it can also cause, because we heard that smoked fish or smoked food.
Hello.
Can also cause or can also predispose somebody to cancer.
Are you asking?
Yes, please, sir.
that can smoke fish
Yes, please.
expose somebody to cancer?
Yes, please. Because of maybe the like how it is preserved.
How is it preserved? I want to know.
Because of this, sir, because of the smoke that I'm talking about. We heard some time ago that
When the issue here is this: when you have a diet that is able to generate any chemical.
Okay.
When you have any diet which, when eaten, right, or when even left for a while, or by the way of the preservation, the packaging, or whatever it is, it will lead to a generation of a chemical in there. Possibly it can lead to that. And it is even known that high protein diets, right? High protein diets have actually been implicated in some cancers of a sort. I can't give vivid that this particular food, I can't really give that. But what we know is that high protein diets, right? Yeah, we can. That is why you can see from this particular point I have here, the yellow one here. Experimental evidence suggests that low protein diet protects against certain chemical carcinogens. Can you see that? By reducing levels of mixed function oxygenases.
Yes, sir.
That means that if you have the high protein ones, will definitely lead to the chemical carcinogens being produced, and it will, the level of functions of oxygenases will be high, and that can affect even the liver and even the breast, as we talked about.
Yes, sir. So it was based on that point that I wanted to clarify my mind, because like the previous knowledge, you know, there were some things that they were saying that any food that is smoked, because of that the smoke contains some chemicals that can cause cancer. And for this point, I've realized that, like, maybe some of the food, when you smoke. Okay, no, this one is protein, it's not fat. Thank you, sir. Sorry.
Okay. I think I saw your Rose, your hand is up. Rose.
Sir, sir, I've also read. Sir, please, I've also read somewhere that high sugar diet predisposes one to cancer.
That is true.
Okay.
I've also read some, but the mechanism and then the theory around it is what we have not really been able to finally come to a conclusion of.
Okay. And then, sir, please, I want you to maybe, I don't know, refer us to somewhere that, so that in our free time, read on the pathophysiology, or how bacteria, wood, and then the others can cause cancer, because it looks somehow rare.
Okay. So I would put a book or some books, the name of some books, then you can go and then look at them. Right. But Rose, have you finished reading even the book, and you are now thinking of pathophysiology?
No, I just want evidence-based. Yeah, that's why I said in our free time, maybe after completion of school, we can try and read it. No problem.
I'll give you those ones after later. But you now let's concentrate on passing this one. Let's concentrate enough on passing that one. Is important. Okay, but I like the fact that you want to read ahead. It's also a good thing. Osei Martin, your hand is up. Osei Martin, your hand is up.
Sir, please, someone put it in the chat that smoked fish causes cancer. In our NTC era, Chairman, I also heard it. How true it is?
Chairman, as long as I'm concerned, this class, you were not even part in the first place because you were busily talking somewhere. We explained what you are asking right now. We have already explained and it shows clearly that you are non-serious and you are not partaking in the class. Hamdia, you can please talk, and let's forget about this research, Matinga. Hamdia, please, you can talk.
Sir, please, my question is, I want to know whether sarcomas and carcinomas, they are all malignant tumors. And then...
Yeah, the carcinoma, the sarcomas, they are malignant. Sarcoma is for the connective tissue. The carcinomas are for the epithelial tumors.
Okay. And please, the benign tumors, they always benign tumors finally get to be carcinogenic or malignant, or it's not always the case?
Not always the case. Not always the case. Not always the case. Definitely there must be exposure to carcinogenic substances or mutagens. Please, do you get a point here?
Yes.
There must be exposure.
Yeah, because a condition like tonsil, I was told that if continuous recurrence of tonsillitis can, it's a benign tumor, but they say with time it can develop into a malignant tumor if not taken out.
Yes.
So that's why I'm asking this question.
It's a very good question, and it's true. I always advise people that when you have any tumor and then thankfully we check and then they tell you, well, it's benign, let them extract it, let them remove it. Don't leave it there like that. Before you know it, I've seen people whose situations or cases were benign initially, but with time, right? Because obviously, Ambia, the causative agent, you remember that we said that oncogenes, they cause both tumors of benign and then what? Malignant.
Yes.
That means that it can start with an oncogene as benign, but as time progresses, now the same oncogene will now transform it from just a benign thing to a malignant one.
Malignant. Okay, sir. Thank you very much.
So we move on to the last part, and then we are looking at the age. And age here, please remember that because of cumulative exposure to these carcinogens, cumulative exposure to Alisewa. Okay. So we have cumulative exposure to these carcinogens. And because when you are old, your immune system is not very active like when you are young. And so when you have them accumulating in there, when your immune system is not very strong, it can initiate and lead to the appearance of a tumor. And before you know it, it can, just like we talked about, a benign tumor, and then later you can have it. And so mostly people that work with certain chemicals and radiations, the surfacing of these tumors only occurs when they are aged or they are old. When they are aged or when they are old. Then we have the last part, which is the gender. And we know that breast cancer affects women more than men. We know that breast cancer affects women more than... So I am done with this one. God willing, next week. Hello, are you there?
We are here.
Yes.
Yeah, so...
Yes, please, we are there.
Yeah. So next week, right, what we will do is that we'll just come online briefly. If you have any question upon what you have read, and that is where you need clarification on, please, I'll be available for you to ask me the questions, and then I will clarify them for you. And then we will be done with the semester. Remember, after that, I will tell you how the format of the questions will be and everything, right? I'll tell you how the format of the question will be and then everything. I think I can see some hands here. Irene Gavo.
Sir, please, I want to make a request. Please, would the slide be available for us?
Oh, the slides are already available. Are they not?
No, sir.
So they are on the Telegram page.
Hey, Madam Gavo, you are now asking for slides. They have been there long ago, please. Hamdia, your hand is up again.
Sorry, sir, I didn't put my hand down. Sorry.
Okay.
Okay.
Osei Trematin, your hand is up.
Sir, sorry. When I raised my hand, I didn't put it down.
And Derek, please, your hand is up.
Doc, please, you promise us to give us the result on the Telegram page, and we are waiting.
Oh, thank you. Please, your class rep, the Kumasi rep, please remind me on Monday, tomorrow. I'm sorry, Monday, so that I would just have it sent. It's there. It's there. I've actually not glanced through to see whether you performed magic or not. I'll send it. I hope we are all okay. Okay, so I think that we can sign off here. I think we can sign off here, and then everything will be good. Everything will be good. So thank you very much for coming to class. Have a wonderful day, evening rather, and relax. Okay, so please read for me so that your passing will be very easy for all of us. Yes. Okay. Bye-bye.
Bye.
Thank you.